Good afternoon, everyone. Firstly, I thank the scientific committee for having me here. Today, let us talk about dry eye disease with respect to aqueous deficiency and what can we do beyond lubricants to treat such patients. First of all, how frequent is aqueous deficiency dry eye? In our clinic, we see around 20% of patients to have a aqueous deficiency dry eye disease and 40% will have mixed, that means evaporative and aqueous deficiency dry eye disease. In the classification, we see the causes to be Sjogren's syndrome, non-Sjogren's syndrome that include lacrimal disease, obstruction, reflex-related diseases, and of course the autoimmune diseases. Now, the basic evaluation of dry eye that includes all our clinical tests can also include something called a Sika ocular staining to diagnose these patients, because when the patient presents to us, we need to classify it as aqueous before proceeding with the treatment. Our Schirmer's test is very important. A low Schirmer's is definitive. Even as an ophthalmologist, we need to take some systemic history and examination to check for Sjogren's syndrome, which is pretty common. Secondary Sjogren's we see mostly for rheumatoid arthritis, systemic lupus, scleroderma, and mixed connective tissue disorders. In aqueous deficiency, mostly the patient has these 3 or 4 complaints. They complain of a severe burning sensation that wakes them up at night. They have to get up to put gels even at the night. And sensitivity to light. Whenever you see them, they will have a squeezing kind of eye motion. This is a lusterless cornea where you can see that the tear film is reduced, and when you stain you see multiple punctate epithelial erosions. This is a case where there are numerous filaments on the cornea in severe aqueous deficiency. So how to treat them? Yes, lubricating eye drops are the initial stay. Viscosity building agent should be used. Lipid containing eye drops are not required. Today, sodium hyaluronate is the preferred choice because it augments the aqueous layer, and extra additions like dextrin and glycerine are important. Osmoprotective agents such as trehalose and erythritol will reduce the hyperosmolar stress. So apart from medical therapy, which includes lubricants, there are other eye drops and systemic tablets that can be used. Rectify the primary pathology. That is, if there is a lid disease or the patient has an autoimmune disease, the systemic treatment should also be started, and then stabilize the surface. So what else can be used? Apart from lubricants, we can use steroids, immunomodulators, mucolytics, and supplements. We will be discussing all these in our future slides. Then you can also use contact lenses, autologous serum, intense pulse light therapy, punctal cautery, amniotic membrane, and the punctal plugs. Now, glucocorticoids, especially prednisolone acetate and loteprednol eye drops, they are anti-inflammatory and they act on all the chemokines, adhesion factors, inflammatory factors. They are an important part of treatment. You can add as a second drug cyclosporin A and tacrolimus. Cyclosporin A I prefer 0.05%, tacrolimus 0.03% topical, and new drug for 5% lifitegrast is also available. Now, the role of mucolytics. N-acetylcysteine, which was first used in pulmonary disease, can be used in aqueous deficiency dry eye. It is available as a mucomix injection. 20% is too strong. Take 4 ml of the CMC and mix it to 2 ml to get a 7% of mucomix injection. We can use autologous serum because tears contain essential components for ocular surface, which is also present in blood. So around 40 ml of blood can be taken and centrifuged and diluted to 20% with saline, and there can be allocated in 5 ml bottles, refrigerator, and used. Next is punctal plugs. This is a more popular abroad than here, but we do see many patients where we can use collagen plugs, hydrogel plugs, or silicone plugs, which are of various types. They go into the lower punctum and they prevent the loss of tears from the lacrimal passage. Now, punctal cautery is a more preferred choice because these cases which are very severe, always do the syringing first before proceeding with the punctal cautery. Remember, this is a permanent procedure. Once you occlude the lower punctum, reversing it by the oculoplasty is a very difficult procedure. So make sure it's really required. You can do both upper and lower punctum in selective cases. Scleral lenses can be used. There is a reservoir of fluid. They reduce evaporation. Make sure there are no synechiae, there is no symblepharon before using this. It also improves vision by correcting the irregular astigmatism. Coming last to the mixed dry eye disease. What if your aqueous deficiency also has an evaporative dry eye, that is your meibomian gland dysfunction? Now, our traditional warm compresses massage may not work. We have something today called intense pulse light therapy, which is selective photothermolysis by using a broad spectrum polychromatic light. This ablates superficial vessels of the eyelids, decreases inflammatory markers, and also aids in collagen remodeling. Now, different devices are available for IPL therapy. The EI platform has something called regulated pulses, where the energy spectrum are precise to stimulate the meibomian glands. They have also been useful in these aqueous deficiency, dry eye, allergy, blepharitis, and in OST due to anti-glaucoma medications. This is a small device where we use it and give shots below the eye in 5 in number on each side, and this is a very easy procedure that can be used in the outpatient department. IPL therapy, apart from the meibomian gland dysfunction and Sjogren's disease, it can be used also for allergic conjunctivitis, blepharoconjunctivitis, and also in pediatric patients. To conclude, any case of aqueous deficiency dry eye disease, first always start with tear supplements, and to that you can add your gels and ointment that stay in the eye for a longer time. In severe cases, which most case it is, add your topical corticosteroids. I might start with prednisolone acetate and then reduce to lotiprane and then finally stop. Do add cyclosporin and tacrolimus. In non-responsive cases, you can use your lacrimal plugs, more importantly punctal cautery or IPL therapy. Use for filaments, you can either remove or use mucolytic agents. And do not forget to be in collaboration with rheumatologists to start oral corticosteroids followed by oral immunosuppressants. And we see most commonly HCQ, methotrexate, and azathioprine being used. And you can use pilocarpine also in order to achieve a complete holistic control of this disease. Thank you very much. Yes, yes, we can use. Rheumatologists do use for quite some time, provided patient doesn't have side effects like excess salivation or excess sweating can also happen with pylo. So initially we give a trial of 1 month where we initially start with once a day and then we increase it to 3 times a day if patient is tolerating. I usually give for 6 months and then stop. Yes, sir.
When to start steroids in dry eyes. I see a patient, about 50 plus patient of computer science students who frequently complains of dry eyes. They have to work for 17 hours or 18 hours. How to grossly manage such patients?
Such patients would mostly fall into the category of evaporative dry eye because they are sitting in front of the system which is causing evaporation of the tears, not aqueous deficiency. So for them, the topical steroids are not indicated. Though they may feel symptomatically, it will be more of a steroid abuse only. So only lubricants and gel works better. Of course, we tell them take frequent breaks and reduce the screen time, reduce the mobile, which they don't do. So the gels will stay in the eye for a longer time, longer retention time. So instead of reserving it for bedtime, we can give once in the morning and once in the evening and add the frequent sodium hyaluronate lubricants and avoid steroids for such patients. Topical steroids only for very severe, bad ocular surface with lot of punctate erosions, filaments, and where there's lot of inflammatory responses, which is usually not seen in these kind of patients with a computer vision syndrome.
Which is better lubricant? Glycerin based or carboxymethyl cellulose or hyaluronate?
All those studies reveal different things. What I have seen is most of the patients are comfortable with sodium hyaluronate or HPMC, that is hydroxypropyl methyl cellulose. So these two are currently my drug of choices. But then every patient works differently. Some patient use CMC for many years and they are okay with that. But my first, because the retention time is longer. So first drug of choice for me is sodium hyaluronate and then second would be HPMC.
Can we use ointment
Yes, yes, definitely.
replacement?
Yes, HPMC ointment. Yeah. Thank you, sir. Thank you. Yeah. Yes, there have been studies, but I haven't tried personally. Um, yes, yes, yes. Yes, we can start with a combination of steroids and this anti-inflammatory, and then once we wean off steroids, the anti-inflammatory drugs continue. But that also, I think they give for 3 months or maximum 6 months, including lifitegrast. But if you go for cyclosporin and tacrolimus, that can be given lifelong. Tacrolimus works very well, provided patient tolerates it. Just a small quantity inside the eye before bedtime for all these patients with aqueous deficiency works very well, and lifetime it can be given. Mm. Thank you.